And there we go. Thank you, everyone. Welcome. We are excited to have you at our third edition of our research webinars for the World Trade Center Health Program. And there's a lot of great information that we'll be sharing. So I'm going to turn it over to Dr. Travis Kubali, our Associate Director of Research at the World Trade Center Health Program. He will start us off with some announcements, and then Dr. Christy Anderson, Senior Medical Officer of the World Trade Center Health Program, will introduce the speaker. Thank you.
Well, thank you very much, Anne, and good afternoon, everyone. There are a couple of updates for those of you that are research PIs on the call. First of all, I want to let you know that the 2022 Scientific Review Panel will be meeting later this month. The 2022 awards, we anticipate that the grants office will notify regarding funding by July. The other announcement that I wanted to make for Dr. Yin is that, as you all know, March 15th, the Type 5 renewals are due. Please make sure that you include research publications so that we have those recorded. Those are very important, as you know, for our planning. And just an aside, 25% of our Zadroga-funded publications are high impact. So again, these are very important, and it's very important that we keep up with these. And we congratulate all of you that have been publishing and doing a wonderful job of that. Dr. Yin also said that later this month, the Grants Management Office will be sending out closeout recommendations. Please be aware of that, and also make sure that if your grant is being closed out, that you follow the format instructions. Those are very important for us as well. And with that, I want to thank Dr. Sigel and his team for the presentation today, and I turn it over for introductions to Dr. Anderson. Thank you again.
Thank you, Dr. Kubali, and thank you everyone for being here again. This is another wonderful presentation, and I'm very excited to hear it. Lung cancer is a public health, has a substantial public health burden. It's a commonly diagnosed cancer. It has a relatively low 5-year survival rate, even when we're talking about local disease. And it's one of the leading causes of cancer-related deaths in the United States, as well as in our member population. The program allows for coverage of lung cancer screening in accordance with the U.S. Preventative Services Task Force Category A and B recommendations, but numerous other organizations, including the National Academies of Sciences and academic centers across the country, continue to call attention to the remaining research gaps in our screening guidelines. We need a better understanding of all the benefits and harms. We need to understand the impact of health inequities and how to find the best strategies to reach and define all eligible populations, and then how to coordinate the best screening efforts we have with risk mitigation strategies such as smoking cessation. It's the type of research that we're going to hear about today that helps answer some of these knowledge gaps, not only the benefit for our program membership, but also for the national and global populations. And we also want to ensure at the program that we're aligned with the best screening strategies for our members. So with that, I'm going to introduce Dr. Keith Sigel. He is an associate professor in the divisions of General Internal Medicine and Infectious Diseases at the Mount Sinai School of Medicine. He received his BS, MPH, and MD degrees from the University of North Carolina at Chapel Hill, and his PhD and Internal Medicine and Infectious Diseases training from the Mount Sinai School of Medicine. He's a clinical researcher and epidemiologist with a primary research interest in clinical factors related to lung cancer and lung cancer screening in special populations, such as persons living with HIV and, of course, our World Trade Center disaster responders. Without further ado, I'm going to turn it over to you, Dr. Sigel. Welcome.
Thank you so much. So it's so nice to be with you guys here today to present our work. I'm presenting on behalf of myself and my co-PI, Dr. Juan Wisnivesky. You know, this has been a project that's been going on through a fairly tumultuous time, but it is still a work in progress, I will say, but you know, we're very close to the light at the end, and I hope you guys will see by the end of the presentation the progress that we've made. So we are working on looking at lung cancer screening among World Trade Center rescue and recovery workers. I'll refer to them as World Trade Center responders pretty much from here on out. So the objectives of the talk are to briefly review the clinical relevance of lung cancer screening to the World Trade Center responder cohort, then present the rationale for this research project, and then describe project results of our various analyses to date. As Dr. Anderson mentioned, lung cancer is a leading cause of, or is the leading cause of cancer death in the United States, and therefore is a pretty substantial public health problem. And as she also mentioned, particularly for more advanced stages of lung cancer, we have low rates of survival compared to some of the other, more commonly diagnosed cancers. But as you are likely aware, lung cancer survival, like many other cancers, does differ substantially by cancer stage. And we do see the best outcomes, the best long-term outcomes for patients with earlier stage lung cancer, suggesting that early detection might have, a substantial benefit to people. So lung cancer, as I illustrated, is a major health problem in the United States. But what about for World Trade Center responders? Well, 50,000 men and women worked on rescue and recovery efforts at the World Trade Center site, and has been the focus of many publications that have come out of the research efforts. We know that many responders were exposed to toxic pulmonary particles, including known and suspected carcinogens. And there has been quite a bit of interest in cancer risk in the World Trade Center responder cohort. And several studies have found increased cancer risk beyond expected rates, particularly in highest World Trade Center exposure groups. Lung cancer has not been one of those cancers where we have seen increased risk. However, previous studies have not found higher than expected lung cancer incidence among World Trade Center responders, but that doesn't mean that lung cancer isn't happening. Lung cancer is still the third leading cause of death and the main cause of cancer deaths in the World Trade Center responder cohort. So why is lung cancer an ongoing concern, particularly in reference to World Trade Center responders? Well, 40% of World Trade Center responders have a smoking history. And as you know, age and smoking are the two most important lung cancer risk factors. But in the World Trade Center responder cohort, many participants have substantial both pre and post World Trade Center non-World Trade Center related occupational lung exposures, which also may lead to increased lung cancer risk. And then we have the other question, the question that has been of great interest to many people is, what is the impact of World Trade Center site exposure on lung cancer risk? Something that we still don't have a great feel for at this point. So these were all component questions that helped to inform our project. Now, I mentioned that many World Trade Center responders had previous occupational exposures, and many of those occupational exposures are exposures that have been previously associated with lung cancer risk. And I'm going to focus a little bit on those. You'll see a focus on those as we move through the some of the work that we've done. But I just want to mention some occupational exposures that where there have been previous associations with lung cancer. So we're probably all reasonably familiar with asbestos. There's a clear association with lung cancer in addition to mesothelioma and other cancers. We have that from a number of retrospective studies with at least one study estimating greater than a threefold risk. Diesel exposure has been previously associated with lung cancer risk. Silica exposure, there has also been reasonable evidence from previous epidemiologic studies with a greater than threefold risk in one large population-based study. And a handful of studies have also implicated cadmium exposure with an 80% risk of lung cancer death in an NHANES study, and also a Belgian population-based study finding associations with cadmium. And these are exposures that we do have some data on, at least in terms of self-report for the World Trade Center responder cohort, that may be contributing additional lung cancer risk. So as I mentioned earlier, we know that patients with earlier stage lung cancer have better survival. And so this is work from the LCAP group, one of the sort of seminal early papers looking at the impact of lung cancer screening with low-dose computed tomography. And what the LCAP investigators found was that screening high-risk smokers with low-dose CT shifted the stage at diagnosis for lung cancer, suggesting a benefit of early detection. And that story progressed over the last really decade and a half, where we had two major randomized controlled trials establishing a mortality benefit associated with low-dose CT screening for lung cancer among high-risk smokers. So here we see the primary results from both the National Lung Screening Trial, which was published in 2011, and then the European Nelson trial, which was published just a couple of years ago. So an intervention with very, very strong, randomized trial support. One issue, though, on the ground in terms of the implementation of lung cancer screening is that we have seen reasonably poor adoption. And this is an issue that our group has looked at using population-based surveys. So we had really pretty much a broad recommendation of lung cancer screening in the early 2010s. And as late as 2018, we're still seeing that of eligible, people that would meet screening criteria, we're seeing less than 20% who are actually going for screening. So adoption is something that I think a lot of us are very interested in and would like to improve. And I think that efforts like what we're doing with this project to really try to isolate the situations where lung cancer screening can be most beneficial could potentially contribute to improved uptake. But one consideration in determining the applicability of lung cancer screening for a particular patient is some degree of consideration of both the harms and benefits of that procedure. And in fact, Medicare requires a shared decision-making session prior to ordering lung cancer screening. And so we do know that, if we screen a group of people, many of them will have a normal test, but then many patients will also have a positive test. However, of those positive tests, only a very small number of those tests will actually reveal cancer. And a test in itself might not necessarily be a harm per se, but sometimes these tests can lead to downstream procedures, which can have substantial harms. And there is a quantifiable number of people, at least based on NLST data, who will be screened and will experience a major harm without any diagnosis of lung cancer. Although that number is small, I will mention. These guidelines actually might be a little bit out of date at this point. I apologize for that. Guidelines are always just changing, aren't they? But I put in this slide just to illustrate that there has been some variability in the recommended eligibilities for lung cancer screening. At least a few years ago, the USPSTF was recommending patients aged 55 to 80 with at least 30 PAC years who had quit within the last 15 years would be eligible for, so current smokers or former smokers who had quit within 15 years, and that smoking cessation and shared decision-making were offered at the same time that screening was ordered. More recently, and I'm not sure if the guidelines have actually changed, but we are moving towards a younger criteria with less smoking exposure, actually based on some simulation modeling work. So, obviously the benefit of lung cancer screening is early diagnosis of lung cancer and potentially definitive treatment. And there are some harms, as I mentioned. Those harms do include just the action of having a false positive test, which can have psychological consequences. There's also the harms of downstream procedures related to false positive tests, such as invasive biopsies and things like that. A theoretical harm is the issue of overdiagnosis, where a cancer is diagnosed and potentially even treated that might never have caused a major problem for the patient. And then there is the uncovering of incidental findings, which is not always necessarily a harm, but can also lead to additional procedures and additional anxiety. And the benefits and harms of screening can actually, they vary according to lung cancer risk. And basically, just the one thing I want to say about this is there may be some additional benefit to identifying patients who are at the highest risk of lung cancer and promoting potentially even more aggressive screening strategies in those groups, and maybe less aggressive screening strategies in lower risk patients. And this is an area, I'd say, of pretty active research and fits in with the context of what we were trying to do in this project. And so I'm getting near the end of sort of the background, but I'd say one thing that sort of informed a lot of what we were doing in this project, one of the reasons that I was particularly interested in working on this project, I'm an infectious disease guy, I'm very interested in HIV, and several years ago, we became very interested in another unique group of patients who may have differences in their harms and benefits associated with lung cancer screening because they have HIV infection. It can have effects on the lung, might affect the false positivity rate, life expectancy might be different. So we used simulation modeling techniques, which I'm going to describe in more detail in just a few minutes, to look at the harms and benefits of lung cancer screening for people living with HIV. And given how well that project went, we felt like this might be an interesting framework to then apply to the World Trade Center responder cohort. So why do we need World Trade Center responder specific data? Well, this is a big group that has unclear lung cancer risk. We have a lot of reasons why we might think, lung cancer risk might be different. They've had significant pulmonary exposures. We don't know, they may have differences in their lung cancer screening scan positivity rate. They're a working population, so they may have actually increased life expectancy, so potentially greater benefits for screening for cancer. And then different subgroups within the World Trade Center responder cohort have different quality of life. And so that can also impact the trade-offs, the harms and benefit trade-offs of a screening intervention. So from those differences, we concluded that World Trade Center responders might benefit from potentially broader screening criteria, or specific subgroups of World Trade Center responders might need to be targeted in screening efforts. And I'll explain what I mean by that as we go through the presentation. So we felt that it was unlikely that a lung cancer screening randomized trial would be conducted that would be even possible or large enough for any useful conclusions, specifically for World Trade Center exposed persons. But as I presented to you, several high quality randomized controlled trials have been conducted in the general population. So how do we take what we know from these really amazing randomized trials and apply it specifically to this population? Well, the technique that we have used in the example, particularly with HIV, is something called simulation modeling, to take high quality data and extend it to new populations that have differing characteristics. So the objective of our research was to optimize the use of lung cancer screening for the World Trade Center responder cohort, to enhance a microsimulation model to replicate the natural history, treatment, and outcomes of lung cancer screening in this cohort, and then identify the optimal screening regimen and eligibility criteria to maximize benefits and minimize harms. Okay, so now I'm going to go through the steps that we've that we've gone through to do almost all of that. The story is not quite complete yet. But the first thing that I want to introduce, as it might be a new concept to some of you guys, is what is a simulation model? This really was the technique that underpinned a lot of what we were planning to do. Well, this is an illustration of a simple simulation model. So a simulation model is what's called a state transition model. And in a state transition model, we take different health states that people can potentially experience, and we estimate the probabilities over time of progression through these different health states. If you use a cohort of identical people, that's often what's just called a Markov model. But if you use a cohort where each person in this simulation has individual characteristics and individual risks, so individual risk of lung cancer, individual risk of success of lung cancer treatment, that's what we call a microsimulation model. And so to construct those models, we need data that informs each of these transition probabilities. Now, this example right here is a very simple model, but what we used in this project was a very complex model. This is what we used, the model that we used in this project was a model called the lung cancer policy model. It's a state transition microsimulation model that comprehensively simulates a patient's lung cancer development, progression, detection by either screening or incidental findings, follow-up, treatment, and survival. It utilizes a rigorous object-oriented design with 40 interacting computer modules that generate the life histories of simulated individuals. And at the time, when we were using the LCPM before this project, these were all just people from the general population, but we wanted to adapt it to represent World Trade Center responders. The LCPM initially populates with cancer-free individuals who may develop lung cancer and then go through those different health states according to monthly transition probabilities. So this is a very, very, very simplified schematic of the lung cancer policy model. The actual model itself takes up like 40 pages of documentation. You know, you can come over to my house later and we can go through all of them if you'd like at some point. But needless to say, it's a complicated, very well validated model. But the lung cancer policy model was built for the general population. Much like we did in that HIV project, we wanted to adapt it to the characteristics of the World Trade Center cohort and to the different risks of the World Trade Center cohort. So here were some of the necessary adaptations that we needed to make of the lung cancer policy model. We needed to understand what lung cancer screen positivity might look like for World Trade Center responders. So we wanted to use information on the proportion of lung scans that might be positive in the responder cohort. We also wanted to get the best information that we could possibly find about lung cancer incidence. That's your lung cancer risk in this cohort, and to understand that incidence information stratified by different risk factors, including demographic factors, smoking factors, and World Trade Center exposure and other exposures. And then we needed to understand the life expectancy of World Trade Center responders. So we were going to need information on life expectancy, again, conditioned on all of these factors that we're interested in, including age, sex, smoking, occupational exposures. And then last, because we want to have quality of life adjusted estimates from this model, we needed parameters associated with World Trade Center responder specific quality of life. So this led to several sub-studies. So sub-study number one was this issue of low-dose CT positivity. Lung cancer screening often leads to false positive screens. In the NLST, more than 20% of initial scans were positive, although only 1% led to a diagnosis of lung cancer. Positive screens often lead to invasive testing, such as lung biopsy, and thus the rate of positivity can be a determinant of the harms of screening. As World Trade Center responders had both World Trade Center exposure and also a reasonably high prevalence of previous occupational exposures, we hypothesized that they might have more frequent suspicious nodules, and therefore the harm-benefit profile might differ. So to assess this question, we used data from the World Trade Center Chest Computed Tomography Imaging Archive and data from the World Trade Center General Responder Cohort Data Center. We used data from subjects that were evaluated by the Mount Sinai World Trade Center Pulmonary Evaluation Unit who received chest CT imaging between 2003 and 2012. Scans were collected, de-identified, and then interpreted by a research radiologist using a standard data collection protocol. and all nodules were cataloged and characterized. Additional findings were also collected. Our primary outcome was the presence of non-calcified nodules on baseline chest CT scans, which we then classified according to lung RADS criteria. We also collected information on demographics, educational attainment, income, smoking history, World Trade Center exposure using the previous validated 4-category World Trade Center exposure variable, arrival at the World Trade Center site less than 48 hours after 9/11 or greater than 48 hours, and then self-reported pre-World Trade Center occupational exposures. And you'll see a lot of these variables over and over again in the presentation. We then looked at the association of these exposures with scan outcomes. So in other words, how did these predict whether or not you were going to have suspicious nodules on your scan? Then, to understand whether or not there was some difference in people that had been exposed to the World Trade Center disaster, we combined the participants from this cohort with the screening arm of the National Lung Screening Trial. So we combined 2 data sets, and that way we could compare among similar people the prevalence of suspicious nodules. So we would look at the World Trade Center group and say, hey, what's the proportion of nodules in this group? What's the proportion in the NLST among similar people? So what we found was that there were a lot of nodules in this cohort. More than half of participants had lung RADS 2 or greater findings, okay? And 5% had sort of the highest level of suspicion, which is lung RADS 3 to 4. And this is the breakdown here. And just what we're looking at here is in the columns, the outcome, so the lung RADS classification of the CT scan, and then some of the characteristics of the patients in each group. And really, I isolated the most significant predictors. And what I would say is, maybe reassuring, I might say, is that the things that were associated with nodules really were the kinds of things that we might expect to be associated with nodules. So heavier smoking history was associated with a greater likelihood of a higher lung RADS outcome, and so was greater age. There were no differences in terms of the prevalence of suspicious nodules according to prior occupational exposures, self-report, the World Trade Center exposure variables that we included. But at least 60% of the cohort had at least one pulmonary nodule. And the lung RADS 3 to 4 patients had a median of 2 nodules. So they actually had more nodules. There was also more pleural thickening in the higher lung RADS group, which led us to wonder if perhaps there might have been some under-reporting of some previous occupational exposures. We did an adjusted analysis. The outcome of this adjusted analysis is basically an ordinal regression where the outcome variable is the lung RADS stage. And what we found, much like what had been suggested in the univariate analysis, was that the major independent predictors of higher lung RADS finding on your baseline CT was age and being in the highest smoking pack year category. And actually, probably the most one of the most robust predictors was the presence of pleural thickening on the CT. So when we combined these data with the National Lung Screening Trial data, we found that there was no substantial association with being a World Trade Center responder and suspicious nodules on your CT scan. So we included those in an adjusted model and found that basically World Trade Center responder status fell out of the model. We did not have the most power in the world in this analysis. I think there were only about 90 patients that met in the imaging archive that actually met lung cancer screening criteria, what the criteria were at that time. I'm sorry, not lung cancer screening criteria at that time, NLST inclusion criteria. So we were only including patients that had NLST inclusion criteria. So at least based on these findings, we concluded that being a World Trade Center responder was not associated with an increased risk of suspicious nodules. And so this would serve as as justification for using just general population prevalences of suspicious nodules in our simulation. So although non-calcified nodules were frequent among World Trade Center responders, they were not associated with World Trade Center exposure or self-reported previous occupational exposures, although we wonder if there might have been some underreporting due to the strong association with pleural thickening and suspicious nodules. They were not more frequent than similar NLST participants, and nodules were highly associated with age and with smoking. And as I mentioned, these analyses would go on to inform the simulation results, which I'll present to you in a few minutes. And we published this a few years ago in the Annals of the American Thoracic Society. So now I'm going to talk about, I think, to me, what was probably the most interesting sub-study so far, which was looking at lung cancer incidence. So analyses of World Trade Center Health Registry linkage to New York State Cancer Registry data through 2008, this is a previous paper, not by us, did not find an excess of lung cancer in World Trade Center exposed people. Similar studies of firefighters and general responders actually found, at times found lower than expected lung cancer rates. But these studies did not consider individual level lung cancer risk factors such as smoking. Well, really, I mean, smoking is a big one. And, you know, another issue why these are, I would say these are tricky studies to do. And one thing that we put a lot of thought into in our analysis is that, you know, the tendency is often to make comparisons. If you're trying to decide if the World Trade Center cohort has higher lung cancer rates, the tendency is to compare against the general population. And I think many of us might argue that the general population is probably not an optimal comparator for determining if there is any sort of increased or decreased risk of lung cancer. So in this sub-study, we aimed to determine lung cancer incidence in a more contemporary data set and compare to a novel comparison group. And we wanted to use this information to estimate parameters for lung cancer incidence for our simulation using data from the entire World Trade Center, blanking on HP now, the World Trade Center responder cohort. So I'm going to show you guys the results of actually two separate analyses. So the first one is from what I would call the Mount Sinai cohort. So for the Mount Sinai cohort, we used the Mount Sinai cohort because in that situation, we had access to Mount Sinai medical records, and we could use that to verify lung cancer cases. So we linked World Trade Center general responder data to any participants who had been followed at Mount Sinai. We then identified all lung cancer cases using a variety of sources. So we used the data center data, we used Mount Sinai diagnostic code data, and we used linked Mount Sinai cancer registry information. And then so we took this broad identification strategy and went back and verified all of the lung cancers and their diagnosis state by chart review. We then used this really, amazing resource of the World Trade Center responder cohort data to get information on demographics, detailed smoking history, and then other, established lung cancer risk factors such as BMI, COPD, personal cancer history, spirometry data that was linked. And then we looked at World Trade Center exposure, again, using the previously published categorical variable and previous occupational exposures to compare to lung cancer incidence. Now, I want to take 1 second and talk about our comparison group in this study. Again, my objective in this sub-study was to determine if lung cancer incidence was higher than expected for World Trade Center responders. And so we wanted to create an accurate comparison group. So to do that, what we did was we actually used a simulation. We simulated a cohort that was identical to our analytic cohort. So the cohort of people that we actually were observing with empiric data, we then created a simulation of those people, and we projected each person's individual lung cancer risk using their personal characteristics. So age, smoking, cancer history, BMI, COPD, family history. And we calculated PLCO lung cancer risk scores for each person in that cohort projected their 6-year lung cancer probabilities, and then ran a microsimulation that actually estimated. We sort of simulated them and then let them develop lung cancer to see how much lung cancer we would actually expect if this was a group that didn't have any influence of other exposures. So this is a schematic of what we did. So we had our actual cohort, the real people, 17,000 linked to Mount Sinai data. And then we had this simulated cohort. And we followed them, both cohorts, for 11 years. So each person was followed in the simulation by the actual amount of time that we had data on them. And then we looked for either simulated cancers in the simulated cohort or actual cancers in the actual cohort. And we compared incidence in those two groups. And so in this study, we identified 70 incident lung cancers that we were able to verify. And traditional risk factors predicted cancer. So age, smoking history, obstructive lung disease, and BMI were significantly associated with lung cancer risk. So low BMI was associated with lung cancer risk. And in our unadjusted comparisons, the World Trade Center exposures were not associated with lung cancer risk. So I've highlighted here, again, an interesting set of factors that I keep coming back to in this presentation, but this is the self-reported pre-World Trade Center occupational exposures. And we did find associations with cadmium exposure and mineral dust exposure. So both of those were associated with a higher incidence of lung cancer in this observed Mount Sinai cohort. Now, this table shows the incidence rates for all of these different groups that I've described. So this is the incidence rate for lung cancer among the whole cohort. So it's 39 cases per 100,000 person years. This is the age standardized incidence rate. And then this is the number of lung cancer cases that we saw in the simulated cohort. And then I've also stratified it among smoking status here. So you can just sort of briefly review those with their 95% confidence intervals. So to determine if there was any increased risk for lung cancer, we then, again, compared this observed cohort to the simulated cohort and calculated an incidence rate ratio with a 95% confidence interval. And what we found was among all participants, there was no statistically significant increase in lung cancer incidence in the observed cohort versus this simulation. Interestingly, we did find a lower risk among the World Trade Center cohort for former smokers than to the simulated cohort. And my suspicion there is that one of the key variables in this PLCO model, the predicted model, is the number of years since you've quit smoking. And I suspect that maybe some inaccuracies in people's self-reported number might be contributing to this estimate right here. But regardless, current smokers, we did not, when we stratified by current smokers, we still didn't see an increased risk of lung cancer. We looked at, in multivariable Poisson models, we looked at predictors of lung cancer among this Mount Sinai World Trade Center responder cohort. And unsurprisingly, age and our various smoking variables were independent predictors of lung cancer. World Trade Center exposures were not, but among the pre-World Trade Center self-reported occupational exposures, we did find that mineral dust exposure was still independently associated with increased lung cancer risk. And cadmium was close, but not quite. So we did find that some self-reported pre-World Trade Center exposures were associated. So in this study, we did not find any increased risk of lung cancer associated with the World Trade Center exposure using a method that also concluded that self-reported occupational exposures may be associated with increased lung cancer risk among World Trade Center responders. In this paper, again, using similar methods that we used in the Mount Sinai cohort. And so this yielded I really, just for space, just included some of the specific predictors. So again, unsurprisingly, age, pack years, and years since quitting were both significant predictors. COPD was a very prominent predictor of lung cancer. But in those analyses, we also found that cadmium exposure, silica dust, and exposure to welding, at least again, self-report, were all significantly associated with lung cancer incidence. And we were able to use these parameters to then create a prediction model, basically a World Trade Center specific lung cancer prediction model. So in this model, you can enter in patients' characteristics and their exposures and get their estimated lung cancer incidence rate. And so that we were able to feed into our simulation. And on the side, to validate some of this, we actually looked at the National Lung Screening Trial and looked to see if, because the National Lung Screening Trial collected data on self-reported occupational exposures. And we looked to see if there was any consistency among some of these self-reported exposures and what we were finding in the responder analyses. And interestingly, in the NLST data, chemical and plastics exposure, foundry work, and welding were all significantly associated with lung cancer incidence after adjustment. So we're getting like a little bit of a mixed bag with some of these exposures. So I want to talk briefly about life expectancy and then quality of life. So using very similar approach, we then asked the data center to use linked death registry data to generate life expectancy prediction models, again, conditioned on all of those same variables so that we would then have consistent parameters for our simulation. And this is what we found. So we were interested in non-lung cancer mortality rates because the LCPM model that we were adapting, it explicitly models lung cancer mortality. Using the team at the data center classified deaths as lung cancer versus non-lung cancer deaths, and then fit cumulative incidence competing risk survival function curves to estimate the baseline mortality curves, basically. Then we fit multivariable models to estimate how specific covariates then estimate that baseline mortality. So this is what that baseline mortality curve looked like. And what you can see here is this is basically the probability of death over time. The pink is for non-lung cancer death, and the grayish is lung cancer death. And then we fit a multivariable model. Again, I've just included things that were significant that then allows us to move that curve up and down to inform the simulation. So, I felt good to see that age was a strong predictor of death. I mean, we would expect that, right? Women had in the responder cohort had a lower risk of death, and there was, an expected increase in risk of death with increasing pack year smoking exposure, and a decrease for quitters according to the number of years since they quit smoking. And in terms of so there was also no association with the World Trade Center exposure variable, but we did again see associations with self-reported pre-World Trade Center occupational exposure. So a 40% increase in the risk of death with silica dust self-report, and a 40% increase in risk of death with wood dust occupational self-report. So those models would inform our life expectancy module, and then last, quality of life. So we took baseline quality of life measurements from the cohort data to allow us to estimate quality adjusted life year gains associated with lung cancer screening. So these would provide weights and basically baseline weights for the model. And we used the SF12 was used in a survey. We had results from over 22,000 participants. We then converted this to the EQ5D so that we could estimate utility weights, which is a number from 0 to 1. And this is what that adjusted linear regression model looked like. We found, so all of the factors included here were significantly associated with quality of life. And when you see a beta that's negative, that means that this factor was associated with a decrease in quality of life. So increasing age, decreased quality of life, very, very small. Being a woman was associated with decreased quality of life. The more pack years of smoking, each additional pack year decreased quality of life. Former smokers had an increased quality of life, COPD. And then there were significant exposures with significant quality of life associations with World Trade Center exposure. So intermediate and very high, both associated with a quality of life decrement. And these were the only three pre-World Trade Center occupational exposures that were associated. But you can see asbestos exposure was associated with a pretty substantial decrease in baseline quality of life. So these formed our baseline quality of life weights. The model itself then has intrinsic adjustments in quality of life as you move through the lung cancer screening cascade. So if you have a false positive scan and you go for a biopsy and you develop a pneumothorax, then your quality of life actually gets penalized intrinsically in the model. So all of those sub-studies that I presented to you, we then used to modify the LCPM framework so that we could then simulate screening trials among World Trade Center responders and provide World Trade Center responder specific estimates. And we are not totally done with this, but the model is running and we are generating results. And I'll tell you what the last piece is going to be in a minute. But what we're seeing here are stratified estimates of mortality reduction associated with screening. And this is measured in terms of quality adjusted life year gains for the general World Trade Center population. So what we've done here is we've taken the entire World Trade Center responder population, some of them non-smokers, some of them smokers, and the only people that meet screening criteria actually get screened. And this is the estimate of what the mortality reduction is across the cohort. And what we're looking at, I know the text is kind of small here, but we're looking at it, we were interested in looking at just the general responder cohort, but then also looking specifically at groups that had specific pre-World Trade Center occupational exposures, because those were some of the most unique factors that had associations with both life expectancy, quality of life, and lung cancer incidence. So you can see that this is men here on the far left, and then our last four columns are women. We do see that women benefit more from lung cancer screening in our model results, and we see that all three of the pre-occupational exposures actually decrease the benefits of lung cancer screening a little bit, but not substantially. And these are the actual population average adjusted life year gains that are associated with screening, again, for each of those groups. And so we can see, again, some of the most prominent gains are among specific, populations with specific pre-World Trade Center occupational exposures. And then the model also allows us to then quantify all of the downstream things that happen to people in the lung cancer screening cascade. And so what we're seeing here, again, each of these groups of 3 bars represents one of those groups from the previous figure. So this is just men from general World Trade Center responder cohort. So we see that if we screen, I don't remember how many people we screened. It might've been 1 million, it might've been 100,000, but we explicit quantifications of both harms and benefits as we start to look at, different sets of screening eligibility criteria. So in other words, screening the general group of smokers starting in an earlier age, going to an older age, versus, potentially specific criteria for people with cadmium exposures or specific criteria with people with, more extensive World Trade Center exposure. So those are the things that we will explore next. So at this point right now, what we can say about the simulation results is that low-dose CT screening has benefit among World Trade Center responders. This is not a surprise. Again, responders meeting the currently accepted criteria for lung cancer screening. We are still in the process of using this to quantify the specific harms and evaluating specific screening criteria among specific groups. And as I showed you in the figure, women in the cohort do appear to benefit more from screening, and that's probably related to their greater life expectancy. The next steps is to compare these different screen is giving expected results, and we just basically need to tell it what to do now, and start to forecast which combinations of eligibility criteria give are the most cost effective and maximize benefits and minimizing harms. And so then we will generate cost effectiveness based recommendations associated with various screening criteria. And then sort of the last piece will be to look at different nodule workup recommendations. So to summarize what I presented, lung cancer is an important cancer for World Trade Center responders. Lung cancer screening is a standard of care early detection tool with a mortality benefit that's been well established in the general population. Suspicious nodules might not be more prevalent than expected among World Trade Center responders. Lung cancer incidence may not be associated yet, maybe, with World Trade Center exposure, but lung function and previous occupational exposures, self-reported occupational exposures, may help to identify higher risk patients. World Trade Center exposure and previous occupational exposures can predict quality of life for World Trade Center responders. And lung cancer screening has different harm benefit profiles by gender and pre-World Trade Center occupational exposure profiles. And so I want to thank this group of people and really everybody that has been involved, and to NIOSH CDC for funding this work. And we're almost there.
Thank you very much for this great presentation. Just to let everyone know, our next presentation will be on Thursday, April 14th at 2 p.m. Dr. Trisande will be presenting on prenatal WTC chemical exposures, birth outcomes, and cardiometabolic risks. So be watching your inbox for Rhonda sending that out to you. Thank you, everyone. Have a wonderful day.